Uh,
Hello, Rajendra, can I go ahead?
Yes, sir.
Dear Pure Urology viewers, good evening, one and all. Today, our topic is related to the PCNL. As you all know, each case of PCNL is different. So, when you wanted to do a PCNL, how to plan the puncture, dilatation, removal of the stones, at the same time, entry into the other calyces, either repuncture has to be done. These are the common things. Many times it is discussed. For seniors, it is repetition. For the juniors, it is learning. So I thought we request one of the senior mini perc and PCNL surgeon who also does both supine and prone, who also does RIRS,
Sir, your voice is not there now.
who also does RIRS, who also does ECIRS, who
Your
also
voice
does.
is not there.
Rajendra, my voice is not there.
Now it's there.
It is coming, sir. Voice is coming for us.
Now it's coming.
Yeah, so it is. I requested one of the senior urologist, Dr. Dilip Mishra, who is well versed with the various types of the PCNL surgeries as well as RIRS and stone management with his vast experience, and he has published also many papers. So let us listen from him. Can you share the CV, Rajendra? So today topic is clinical scenarios. Uh, uh, PCNL different clinical scenarios. Speaker Dr. Dilip Mishra from Agra. Next. So Dr. Dilip Mishra is MS, MRCS, FRLS, FICS, MCH urologist. Currently, he is the head of the department of Patanjali Hospital Research Center in Agra. Uh, Clinical work involves special focus in endourology, stone diseases, and reconstructive urology. Former chairman of Youth Wing of USA and eminent faculty of the Indian School of Urology. Reviewer for various urology journals, including Indian Journal of Urology, Journal of Endourology, Asian Journal of Urology, Urolithiasis. Faculty at state and national international urology conferences. Awarded the JUA International Scholarship in Tokyo, Japan in 2012. Awarded the UAA Youth Section Fellowship in the year 2014. Conferred Fellowship of the International College of Surgeons, Chicago, USA. Distinguished Young Urologist Award, Urologist Association of Uttar Pradesh 2023. So amazing CV. And with this introduction, I request Dr. Dilip, who is a close friend of me, to give his talk on the various clinical scenarios of PCNL. Over to you, Dilip. Thank you very much.
Thank you, Chandramohan sir, for a kind introduction. I am very happy to be back again on Pure platform for this talk of mine, which you had asked me before. And I am really inspired by you of late, your latest achievement of having the first telesurgery in that pediatric patient we saw in Goa also when you presented. And it was amazing. And I am really amazed by the energy you're having. You will travel all around the world, keep on operating, and then you have time for your sessions, and you'll every month you'll conduct those meetings for youngsters. And I believe I have so many youngsters, and you are helping them immensely in so much ways. You know, everything means so many programs you are doing for the young urologists in
Thank
India,
you.
and it's really commendable, sir. And
Thank
I'm very happy to be associated with you, and I'm very happy that you consider me a good friend. Thank you, sir. So, without wasting much time, I would proceed on to the talk, which I prepared for this. 1 second, sir. I'll just share my slides.
Yeah, please.
So, are the slides visible, sir?
Yes, clear, very clear. Yes, sir. You can enlarge the screen.
Yeah, I'm just trying to do that, sir. 1 second. Yes, now it's full screen.
Yes,
So
sir.
my
Fantastic.
topic for today's talk is PCNL in different case scenarios, and I will be trying to discuss different multiple cases of PCNL in which we had found some difficulty or which were very challenging cases. Simple cases, as you know, you have been teaching around so many years, and everybody can do, means almost everybody is well versed and they can do. But problem comes when you have got a different case in a different type of stone, whether it's an ectopic kidney or it is a pelvic kidney or some other problem is there, then you find it difficult. So I would like
Yeah,
to focus on those cases where it is not very straightforward to do a PCNL, and then how to approach those cases. That I would like to discuss in this talk here right now. So this is
very good.
the poster which you have sent already. So my talk will proceed in this case scenarios. First, I have six cases. First one is a PCNL in a gross splenomegaly patient. Second is a, a guidewire remnant which was left behind post PCNL, that we will do. Then we will do lap guided PCNL in ectopic pelvic kidney. Then how to approach a staghorn stone, that also I would like to explain. And the fifth case would be upper calicus exclusion post PCNL, and the next is an intrathoracic kidney in PCNL. So I would, without wasting time, I would go ahead with the first case. This was a case of a partial staghorn stone with gross splenomegaly. So he was a 40-year male with left flank pains in 6 months. He has had a history of liver disease with cirrhotic changes and gross splenomegaly. His platelet counts were 64,000, good enough for doing a surgery. And PTIN was 1.5, creatinine was 1.2, hemoglobin was okay. So these images, as you can see here, multiple CT sections I have shown here. Here you can see this is a coronal section. You can see multiple stones, which is like a partial staghorn stone, is seen in the lower calyx and going into the pelvis. And it was like a 2.65 centimeter stone. And this is the axial cut. Here you can see. Here you see the spleen is huge and it is coming almost below the lower pole of the kidney. And if you see like this, there is no way you can do a PCNL in this case. Here again, the spleen is almost covering completely the kidney. This is an axial cut. It is a very small window from
Sir,
here.
one small interruption, sir. One small interruption.
Yes, sir.
In previous days, IVP used to be done when the
Yes,
CT is not there. Do you
yes,
think before you start how you have done?
yes.
Nowadays, everybody is replacing with CT. Probably this is one of the reasons, sir.
Yeah, because if you do IVP, you will not know where the spleen is, where the liver is, where the colon is. But if you are doing a CT scan, you can see the kidney, you can see the system. Maybe not the pelvic system completely, but you will know exactly how the stone is delineating, whether it's an entry calyx or it's a posterior calyx. That can be approached, that can be seen when you're doing axial cuts, and then you can very well see all the surrounding structures which are present around the kidney. So you can easily make out how to plan a window from where you can enter into the kidney. I feel that is a very big advantage of a CT scan over an IVP.
Yes,
IVP,
sir.
whatever IVP shows, you can always see while doing an RGP actually.
Yes, sir. That is correct.
Isn't it, sir? So that's what. So we did a CT scan, NC-CT-KV we did, and we could see here. You can see this is stone is in the anticalyx. This is the posterior calyx, and kidney is the spleen is all around. So and the stone was very hard. The Hounsfield units of stone was 1650 Hounsfield units, and I was little worried how I am going to approach this case for PCNL because it's a bulky stone. I was not very confident of doing RARS in this case, and the patient was also of a poor socio-economic strata actually. So what I thought I would do a PCNL in this position, I put in a bolster here and a bolster here so that I would left the flank abdominal area free so that it will help the spleen to fall freely and go anteriorly, leave more space posteriorly. And then I also had an ultrasound and CM, both were present in the OT for making this puncture because I did not want to go through the spleen while making this puncture. So once I saw the CM images, you can see this is the outline of the spleen in the red you can see here, which has been outlined here, and the kidney was medially. So there was a good window was there through which I could make a puncture. And with the ultrasound guidance, I reconfirmed whether spleen is not coming in my way. And then since it was a very bulky stone and it was packing the calyx, so I had to make a RGP and then I made a puncture in this calyx and then I proceeded. So in such type of cases, you need to be very vigilant. You have to plan accordingly how you're going to go about it. You need to have an ultrasound and then you have to plan it. So I was able to make an puncture into the calyx and go into the pelvis. Then following that, I did a single step dilatation and a mini perk I started. I started with a mini perk because there was not much space in the inside the system. So when you have got a packed calyx, you need to be little vigilant, because if you straight away go with a large sheath, then you might stay outside the system and it might bleed a lot. So in such cases in which the calyx is packed with stone, then you need to somehow get the guide wire in and start with a smaller tract first, and then once you start removing stones slowly bit by bit, and then you create some space, then maybe you can proceed on and insert a bigger tract, which I did in this case exactly. So
Sir,
slowly and
are
slowly.
you medial, sir, in the in relation to the rib and paraspinal region? Can you individual pick if it is there, or enlarge this pick so that entry point we can see, sir?
No, no. Medial means I didn't understand. What are you asking, sir? I didn't get it. What do you mean
To
medial by
avoid the
medial?
spleen, of course, you used
Yes,
ultrasound where
yes,
the
yes,
entry point has come on the skin. Normally, it is
yes,
below the 12th rib in the paraspinal, a little away. In this
yes,
case,
yes,
in
yes.
any gross deviation, it has come, sir.
Yeah, you see this picture, sir, here, which I am pointing, and it was little medial, not so medial, but it was little medial, obviously, because I wanted to avoid the spleen. The lower polo is here, so I wanted to
Yes,
avoid
sir.
it. So it was little, say, 3 to 4 finger breadth away from the paraspinal area, actually.
Okay, okay, okay.
So following this, I was able to completely clear the stone. And this was the pre-op image. Unfortunately, I don't have a video of this one, because anyway, it was nothing great after puncture has been made and you have cleared. So slowly, I went with the mini perk first, and then once the mini perk was done and I could create some space, then I instantly introduced the bigger sheath, and then I could clear everything. And here you see the stent is in place and there was no stone left behind. So that was about this case. So take home messages for this case is, so you have to see the axial cut images of CT scan to find out a window for making a puncture. You should have an ultrasound in OT for assisting in puncture. Prone position helps as the viscera can go down and leaving more space for puncture. I think this was a very difficult case to be done in a supine position. I don't think this could have been attempted in a supine position. What do you say, sir?
Yes, sir. Absolutely agree, because you have to do parallel puncture. There is no
Yes.
question. This is one of the rare cases where supine has no role.
Yes, yes, sir. And we have to be very careful in such cases that we do not injure the spleen or liver, whatever is coming around. And even after all this armamentarium, even if you're not finding a murder, then you have to go ahead and do an RIRS, because if PCNL is not possible, RIRS is the only answer. So that's what is my message with this case. So I will go on to the second case. This is a case of a guide wire remnant post PCNL. How to manage, that's what I'm going to show you. So again, this was a case of a, I think, 25-year-old lady. She is having a stagnant sort of stone in the left kidney, and you can see in this one multiple stones were there in lower pole in different calyces, and a large component was there in the pelvis. And this is a RGP picture. You can see multiple dilated calyces were there. So this was the preoperative X-ray as well as RGP. Unfortunately, I did not have a CT in this patient, as you asked in the previous case. So I attempted this case. This was a Ayushman Bharat case actually, and we planned a puncture through this calyx. So uh, nothing great in this case. I could make a puncture. I could dilate the tract. I could clear all the stone, and everything was looking fine. So finally, in the end, when I saw everything was clear except for one this small fragment which was there and which is going above the 12th rib or 11th rib. So most of the stone is cleared with one single track, and one small suspicious fragment was there in the upper calyx. It was above the 11th rib in position. So what I did, I thought, okay, I'll make another small puncture, and I made a stone guided puncture which was supracostal, and when I pushed the guide wire, my guide wire seemed out of the system. So what I thought, okay, my guide wire is out of the system. I need not place the guide wire. I withdrew the guide wire. So once your needle is there and your the guide wire was a Terimo guide wire, 0.035-inch Terimo guide wire, I withdrew the guide wire. So what happened, because of the sharp edge of the needle, the outer covering of the guide wire was left behind, which you can see here, which is in the rounded red. And it was left there and the guide wire came out. So I was in a soup, like what to do now. The remnant of guide wire is still there, and I don't know where it is exactly. So then what I did in such type of situation, ultrasound also might not help because this is just a guide wire. It's not a stone which can direct you where it is exactly. So I attempted a second puncture over the guide wire remnant. And when I did this puncture, the guide wire went straight into the ureter. And I thought, okay, so might be that some part of the guide wire is still inside the system, and I might be able to retrieve it from the upper calyx. So I dilated that tract and went ahead inside. I did a scopy, and it revealed that guide wire, um, uh, the guide wire which I placed in the system, but the remnant was still not formed. It was outside the system actually, and I could not find it into the upper calyx or into the pelvis or anywhere near it. So even after doing scopy, I could not find it. So what I did next is I left this guide wire and I made another puncture, which was again directed like a stone guided puncture when you're making a secondary puncture. And I made a puncture over the guide wire remnant. And then this guide wire, which you see here in this picture, is guide wire is going and outside the kidney and coiling somewhere near the remnant. And then I dilated the tract and then I went ahead inside to the nephroscopy. I was little jittery and it was a difficult situation to face actually at that time. Then this was the nephroscopic view, and this was the guide wire remnant which I took out. This is a small video of the nephroscopy of the area where when I went in. You can see the guide wire remnant in there, and I could easily remove it out. I held
Very
it.
difficult clinical scenario. Difficult things.
So what I did for this case, sometimes the similar thing happens with stones also. Sometimes while fragmenting, some stone fragments might go out, and you don't know exactly what to do. This I was lucky in this case, I would say, because I was able to retrieve it with the skills whatever I have. What do you suggest, sir? If you sometimes if a stone fragment is there and it passes out of the system, and whether should we follow it and go make a puncture outside the kidney and try to remove it, or should we leave it behind? Chandramohan sir, hello, can you hear me?
Yes, sir.
I can hear you. The only thing I wanted to ask you is,
Yes, sir.
hello, how can we prevent this guide wire peeling off? Is it that you have to remove along with the needle in such situations? Why it happens? It happened to me also. It is very annoying situation.
Yes, sir.
How
Yes, sir.
this can be avoided?
Wha-
Is it that
if
guide wire is
I
old?
Yes, yes. If it is an old wire, it is definitely more dangerous actually because the new guide wire will have a smooth covering and it might come back out of the needle. But if it is a old wire and if it coils around the needle, then when you're pulling it out, the outer covering of the wire may remain behind. So, as you said, you if you want to remove it, you better remove it with the needle, otherwise it will get left behind. So again, in this case also, I could clear it. I was lucky, but then uh, try not to withdraw the Teramo guide wire from IP needle. You should not panic in such situation. Try bullseye or freehand technique to place tip of the IP needle at the stone guide wire remnant. Small tracks will help in this situation. You need not make a big track in these situations. And in
Sir,
case
I
of worst
wanted to
case,
ask you, when the
yes,
guide
sir.
wire is not very much into the pelvis or in the ureter, just coiling around the stone in the
Mhm,
parenchyma, when you are
mhm,
dilating, it may come out and altogether you may fail. Can you
mhm.
suggest what are the tips? For example, guide wire is 1 centimeter coiled 100% nearer to the stone. You are happy with the puncture. Then
Mhm.
not to get out of the system guide wire.
Yes.
Do you use sequential dilators or Alken? What will you use, sir?
No, first of all, sir, I generally want if there is a if the sto if there is a packed calyx in the kidney and you are trying to just make a puncture on the stone, and then what I do is generally I'll push some saline. Once I have my needle is inside, I am sure that water is coming, and then my needle is inside. I'll push some saline to create some space around the stone, so that there is some space, and then if you pass a guide wire, generally it goes in, and it might call into the pelvis or into the ureter. So that is my first aim, that a significant amount of guide wire length should be inside the pelvic system before you go ahead and do dilatation. Because if a very small amount of length is there inside the calyx, then what I generally do is I will just take a single step dilator, that is a screw dilator, and go. Because if you keep on doing multiple dilatations, there
Yeah,
is
yeah, yeah.
definitely a chance that it will come out actually.
Exactly. Okay, okay. Good point, sir. Very good point.
Okay, sir.
Okay.
So this was done. So I'll move on to the next case.
Yes, sir.
So next was lab-guided percutaneous pyelolithotripsy in an ectopic kidney. So this was a Mr. CK, who was a 28-year-old male. His chief complaint was pain in the abdomen, no comorbidity. Ultrasound suggested stone in the left ectopic kidney. I got a CT straight away, and you can see this is the reconstructed image, and this stone is lying just inside the pelvis, in front of the sacrum. This was the axial cuts. You can see the kidney is lying in the pelvic area, and it is facing anteriorly, the stone in the pelvis, and multiple images are there. This is again some coronal images, and you can see the kidney inside the pelvis. So, what is the armamentary we need for tackling this type of stones? You need laparoscopy instruments. You need to be a little bit well versed in laparoscopy. You need PCNL instruments as well. You need two camera units, because one camera unit will be there focusing on the laparoscopic part, which is going inside the abdomen, and you are seeing where you are going. And the second camera unit you will need for doing the PCNL. So, you need two camera units in this case scenario. And then you need C-arm and ultrasound guidance as well sometimes. So this was the case. These are the pictures of the case, what I did. So I first created a pneumoperitoneum. I inserted a varus needle, created a pneumoperitoneum. And then this is the whole OT image, because two cameras are needed. Then we put in a laparoscope, and we were seeing where the kidney is. And along with that, C-arm is there, which is with which we are directing the puncture actually. So here you can see I am trying to make the puncture under the C-arm, and the laparoscope is showing me how my needle is going. In this case, luckily, there was not much bowel over the pelvic part of the kidney, and my puncture was directly into the pelvis, not through the parenchyma as generally happens in a PCNL, because the parenchyma was all behind actually. You cannot go
Correct.
behind. You have to make a. It is not a proper PCNL actually. It is a pilotomy, you can say, or pyelolithotripsy, whatever you can say. It is not a proper
Correct.
PCNL, because there is no parenchyma through which you are going. You are going directly into the pelvis actually. Actually, in this type of cases, you can very well go ahead and do a laparoscopic pyelolithotomy also. So I decided to do PCNL. I made a puncture with the needle. And then under same guidance, I inserted a guide wire and then inserted the 26 French implant sheath. It was quite a big stone actually. And then these are the RGP images. Here you can see this is the camera which is showing me. Here this is the ureter catheter which is already placed beforehand. This stone is there. And then this is the RGP. You can see all the calyces here, and this is the stone here. Following this, the puncture has been made. After this puncture, we inserted a guide wire, and then we dilated it, and then we made a bigger tract. So this is the intra of images in which we can see the stone. I have put in an emphasis sheet, and I had to use. It was a very hard stone. I had to use shock pulse. This is the shock pulse which I am using. The shock pulse I was using, so that I did not wanted any of the stone components to go out into the abdominal cavity actually. Then, since it was a very hard stone, I could not really get ahead get with the shock pulse. So finally, I had to take laser in this case actually. Laser, it was much more controlled actually, and it was not moving around so much, because with lithoclass or shock pulse, what happens is you are having ballistic effect. And if you are having that ballistic effect, your implant may get out of the system, and all the water and stone fragments might spill inside the abdominal cavity. So you have to be very careful in such scenarios. And then with laser, slowly, I fragmented all the stones and brought them out, and then I placed the stent in this case. So this is the picture in which you can see the stent is placed, and this is the final picture in which you can see the stone is all clear and the stent is placed, which is seen in the pelvic area.
Sir,
So this
I
was
wanted to ask a question. In
yes,
what
sir,
you
please.
did is the best. I had a similar case.
Yes, sir.
Pylo PCNL is better than pyelolithotomy because if any fragment or any stone cannot come out, the extension of the incision can lead to bleeding. And if you wanted to
Yes.
go from one calyx to other calyx, it is not possible easily. So if it is a snugly fitting large stone, except the amplage part, which you mentioned correctly, that if you are, I don't know the word, I'm first time listening, stick, what did you say, stick, um, uh, um, what is that effect, sir? Stick.
Shock pulse. No, I was using shock pulse. No, I didn't
Yeah,
understand.
yeah. It can go out, and it is a
Yes, yes.
disaster.
So
And sometimes
if
if
you
the
are,
amplage sheath goes out, as you said,
then
it is
everything will
very
spill inside
difficult.
the abdomen cavity.
Yeah, sir. Yeah, that's correct.
Mm.
So pylotomy needs wide suturing, whereas this
Yes.
you may not suture also.
Yeah, you may not. So I did not suture in this case actually. You're very
Yeah.
correct, sir. I did not suture it and it healed by itself because stent is there and there is a catheter, so it will heal actually. So
Correct, sir. Correct.
for this one again, the take home message is that you should see the axial cut images of CT scan to assess the kidney position and find a window for making a puncture. Assistant urologist should be there to help with lab guidance. Be careful to keep bowel away and aberrant. We have to be very careful about the aberrant vasculature because the kidney is in an abnormal position, so there might be some other blood vessel coming from somewhere. So you need not you have to be very careful about the vasculature part also in this case. And it's not a usual PCNL as the excess sheet does not go directly to goes directly to the pelvis. It is not going through the parenchyma, so it's not a usual PCNL as we say. And use laser as pneumatic may cause vibration and expulsion of blast sheath. And again, the same thing, RIRS has to be prepared if PCNL is not possible because sometimes the scenario will be such that you're not getting any window, bowel is so much bowel is in front of the kidney and you're not getting any mood, then you definitely have to go ahead and do an RIRS in such type of cases actually. So I'll move on to the next case, sir.
Yes, sir. Yes, sir.
So the next one is staghorn. We all of us keep getting these staghorn type of stones, and sometimes the youngsters might be perplexed, like how to go about these staghorn stones because they are very bulky and big stones, and how much time it will take. They might bleed, and also I wanted to showcase this one also in this pure lecture that how should we approach a staghorn stone. So this was one of the biggest dragon stone which I have faced in my clinical practice, and you can see it is almost occupying all the calyces as this is the 3D reconstruction images, and here you can see it is completely occupying all the system and images here also. So what I did was, so when I do such cases, uh, luckily in this case, the kidney was little bit low and I did not have to go for any supracostal puncture. So that was, I was lucky in this case. But even if you have to do a supracostal puncture, you should not be worried about that. Just 2-3 days back in Parcon, similar staghorn stone case was there and I had to make a supracostal puncture in that case and it went on very well actually. So similarly, in this case, what happened? So what I do is I plan beforehand that okay, in this CT image I can see multiple stones in multiple calyces, so I have to make whatever punctures I have to make. I'll plan those guide wires and keep them beforehand only. You need not like make one puncture and put one guide wire and dilate and clear. So before going ahead and clearing the stone, you have to place all the guide wires beforehand into the system. So here you see I made a first upper calyceal puncture in the upper calyx and put a guide wire into the pelvis. The second puncture which I made was into the middle calyx. Here you can see the second picture, and I placed a second guide wire, and the third guide wire I placed in the low calyx, and I placed it into the system. You can see multiple guide wires which are coiled inside the kidney in this case. So following this here, in this picture, you can see all the three guide wires has been placed beforehand only because I don't want that once I cleared half of it and I'm not, once a large tract is already in place and then you are putting in contrast and you're not getting the opacification in the desired calyx, then you're it's not going to be an easy puncture later on for making a secondary puncture. So better to make all your punctures beforehand and keep the guide wires. So following this, I started with the lower tract. So after you have placed all your guide wires, you plan uh, you dilate that tract through which you feel that you can clear most of the stone. So mostly in such type of cases, there will be one calyx in which the most bulk will be there, and that will proceed take you to the pelvis, and you can clear most of the stone through that one single tract. Similarly, this is what happened here in this 26 French tract. I could clear all the lower calyceal as well as the pelvic stone, and only those three stones are remained after and using the lower calyx. Then I proceeded on and I went to the middle calyx, and there were some stones left behind in the pelvis which were cleared by this middle tract. And even after doing this, because large tracts are there, so the maneuverability is not so easy actually. You cannot go from one calyx to another so easily in such type of cases. If we are using a mini PCN, it's easy actually, but with a large tract, it's not so easy to go from one calyx to other. So then I made another puncture into the upper calyx and I cleared all these stones with that one. So this was the final picture. You can see three implants are there and the guidewire is going into the pelvis, into the ureter, and all the stone has been cleared here. And then I finally placed a DJ stent. So this is the video of the same case in which I had to use soft pulse as well as pneumatic pressure both in this case, and it was a large bulk, so it took around 2 hours for me to clear the whole stop with all the armament failure forms. So this is the final picture. You can see all the three implants are in place. This is the amount of stone which I removed from here. And even after making 3 punctures, the urine is completely clear. You can see there is just a little bit of tinge of redness in this urine, and there was not much bleeding actually in this case. So that's what I wanted to highlight, how to go about a stag-on case if you have such a scenario. So the take-home message for this case is always take consent for 2 sittings. It's not always possible that you will be able to do the whole case in one sitting. Do a good imaging, CT urography to assess every detail beforehand. You should assess the stone load, density of the stone, and the anatomy of the pelvic system beforehand. And all the punctures needed to be on table after doing the RGP. You cannot plan the puncture on CT scan. You can in a way, but I would suggest, I would recommend that all the punctures should be planned only once you're doing the RGP on the table, because that will give you a much more clearer picture actually. And you should proceed stepwise with safety first approach. You should not keep on continuing if the bleeding is happening. You should stop the procedure, put in a nephrostomy, and say we'll do in a second sitting. And be always ready for blood transfusion if needed. So that was about this one, sir.
Excellent, sir. This case you presented very well, and there is nothing to discuss in this. You presented so well that all the cases you park. Sometimes only issue is if the guide wire doesn't go and park, because it is so much impacted one,
Yes,
then it becomes issue. But you could park nicely with space.
Yes, sir. So, as you said very correctly, sir, sometimes this will happen because the calyx is so packed that you cannot go in. So, what has been described previously, and previous our teachers have told us that you put in the guide wire if it calls there only, and then you go with the other side of the implants inside. You don't take the beveled edge of the implant and go with the straight edge of the implant and go with that side inside. And then slowly you start fragmenting and remove some stone, and then you will get some area and you can park your implant inside and then you can proceed with it.
Yes, but that is not sharp. Dilatation may not be so easy.
I
It's
agree,
not
sir. I agree.
beveled. So while doing dilatation, rectus sheath dilatation,
Actually, it might
sequential
lead to a lot of
dilatation,
bleeding actually. Yeah.
it causes more bleeding.
Yes, yes, yes.
Anyway, good point, sir. Very nice case.
Okay, sir. So I would move on to the next case. I think this is the 5th case. So this was a post PCNL infundibular block. It was an isolated calyx. This case was done by Madhusudan Agarwal sir and me together actually. So I would just say this was a very rare case scenario which we face in our clinical practice. So this was a history that he was a 46-year-old male who had left flank pain for 3 months, and ultrasound and IVU suggested multiple calluses in the left, multiple calculi in the left kidney. Blood reports were within normal limits, and he had undergone standard PCNL elsewhere actually, and then finally he was referred to us for further management. So this was his initial X-ray KEB. Here you can see these are multiple stones. This is the pelvic stones, and this 1, 2, 3, 4 multiple stones are there. And this is the IVP image. Here you can see there is the upper calyx, and these are multiple stones in different calyxes. This is again enlarged image of the same old picture. Here you can see multiple stones here. And this is the IVP image again, enlarged one. So, so what was planned was he underwent the first PCNL, which was done elsewhere. This is not done by us; it was done elsewhere. So it was PCNL was planned from an upper calyx. Initially, an upper calyx puncture was made, and this whole stone, the pelvic stone as well as the lower calyceal stones, all the stones would be cleared from that upper calyceal puncture. And PCNL was placed in the upper calyx, and this middle calyx stone, which I marked in red, it was left banned for doing in a second sitting, as can happen always in a PCNL case. So following this, once the patient went away and came back home again, the RGP and as well as the nephrostogram was done, and you could see there was no communication between the upper calyx and the pelvic calcium system here. So this was done in outside, and since there was no communication, we could not proceed with the PCNL, and it will become a problem because if you remove the PCNA in this case scenario, the PCNA will keep the tract will keep draining, and it will become an Percutaneous fistula, and you will never be able to salvage this. So this is the RGP picture. Actually, you can see you are doing an RGP, and there nothing is going from the pelvis into the upper calyx here. And similarly, in this one, you're doing RGP as well as nephrostogram at the same time, and you're trying to pass a guide wire here, but nothing is going into the upper calyx. There is no communication here, actually. So what we did, we planned an operative position, like modified Valdivia position, as we do in a supine PCNL, and we plan to do a synchronous ureteroscopy and a mini PCR in this case. So this was the position of the patient. As you can see, we have not draped the patient, and we just took pictures to show the position actually, as we generally do. And again, the same picture was there when we repeated this nephrostogram and RGP in this one. I don't have any operative picture, but what we did was we did a mini PCNL from the upper calyx, and we did an ureteroscopy from the ureter, and ureteroscope was passed up till here in this area, and PCNL from above. And then we had to, just there was just a small, what I should say, sinus sort of thing was there in the upper calyx, and we just kept on lasing with the Holmium laser. We cut through in that, and we reached in this area. So with approach from above and below both sides, we could create a tract which was obliterated because of some reason. And following this, we put in a this stent, endopilotomy stent through that tract into the upper calyx and into the bladder. And this stent was left there for 3 months actually, so that the tract becomes mature and it does not have any trouble. So there are multiple. I did a literature review of this case, and we could find that this mandibular stenosis after PCNL happens quite often, say 2% of the cases in this series. And there is always they have used ureteroscope in Holmium laser for treatment of this whole infundibular stenosis. And this is again a sort of Friley syndrome which can be treated by this way. So finally, on follow-up, we found that the digestant, which was removed after 3 months and followed up with ultrasound, revealed that minimal dilatation was there in the upper calyx, but patient had been asymptomatic. There was no problem. So the take-home message for this case is uh, we should respect the infundibular anatomy in PCNL and use an access tract which does not erode the infundibular mucosal lining. So if the infundibulum is narrow, you should not pass in a bigger size of access sheath into the infundibulum so that the mucosal lining erodes and it becomes raw. So that will lead to this type of problems. And if there is an infundibular injury suspected, you should leave a stent across the infundibulum. That will help. And laser infundibulotomy is established procedure in such situations. So that was about this case, sir. If you want to ask any questions, I am here to answer, sir.
The only thing is that after remove, how many days you will keep the stent? After removal of the stent, what are the chances of restenosis? These two things, and long-term follow-up is required by MR
Yes.
urograph, which will
Yes.
show the tract, because sometimes it's like core through the
Yes.
parenchyma or fibrous tissue may close. But anyway,
Yes,
that
yes,
is
I
the
agree.
I
I agree
use
with you.
transillumination transillumination through the maximum transillumination where it is coming, so
Yes.
that the parenchyma is not there.
Not
We
there, I
have
agree.
yes, sir.
I completely agree with you, sir. Because we need to find the area which is closest between the pelvis and the calyx, actually. If you have a
Yeah,
bigger
yeah.
area, then it might again reach the nose. So that's
Correct.
what we did. We kept the stent for 3 months, and then we followed it up also, and it was okay. There was no problem actually,
If the
and he
kidney upper
started.
pole is functioning, definitely urine will keep it is open.
Yes, sir. Yes, sir.
That is also there. Anyway, very nicely done. At least you have saved. Otherwise, it
Yes,
might
sir.
have
Yes, sir.
atrophied.
It might otherwise he might have developed a fistula or might have to go ahead and
Yeah,
do a partial nephrectomy for him.
partial nephrectomy for that. Yes, sir. Correct.
So coming on to the last case of the evening, so this was a PCNL and intrathoracic kidney. This is I think, one of the rarest case scenarios. I think many of us would not have seen. And this case again, we did in Rainbow Hospital with MS Agarwal sir, Madhusudan Agarwal sir, and this was a completely intrathoracic kidney in which we did a PCNL. So this case was a 54-year-old male history of pain in the back. CT shows the left kidney in the thorax with a pelvic stone. And DJ stenting was done already elsewhere and it was referred to us for further management. And his biochemistry was within normal limits. So these are the CT images you can see. This is the axial cut images. Here you can see the heart as you can see. And this is the dilated kidneys which you can see in this, which is lying right behind the heart actually. And here is some lung area here. So the kidney is starting in the uppermost part of the retroperitoneum and going into the mediastinum. And here you can see the dilated, nicely dilated kidney can be seen, which is right behind the heart, and lung can be seen on the side. So these are the sagittal images where you can see the kidney is lying against the ribs here. It is very close to the ribs here, and this is nicely dilated upper calyx. This is the contrast which is in the system, and this is the stone here. And there was a stent also in place, which was placed elsewhere. This is the kidney which you can see inside the thorax. This is again reconstructed images. You can see one right kidney is normal position, left kidney is gone high up into the thorax, and these are the reconstructed images, very nicely delineated. So the CT report showed that there was 70 stone in the left renal pelvis, which was somewhere here, and you can see the kidney, the almost going up to the I think fourth or fifth rib level actually. So what
Yeah.
we did, what happens in this type of situation is actually the kidney is not inside the pleura actually. So the kidney is inside the mediastinum behind, in between the two lungs actually. So even if you make a puncture into the kidney, it will not be going through the pleura, but it will be going directly to the kidney, not through the pleura actually. So that's what we thought. And this is the RGP images. You can see here is a stone, and in the second image, this is the ureter catheter, and this is a stone. And then we did a RGP, and you can identify as it is like an elongated system actually. So we made a puncture just above the stone because we did not want to, and it was a very, very, very medial puncture because we wanted to avoid just paraspinal area puncture was made so that we avoid any intrusion into the pleura or anything. And following this puncture, we could place a guider which went into the upper calyx, and then we dilated the tract, and it was again a mini PCNL here, and then we could clear all the stone, and we could place a stent. So
Extraordinary case.
this is some of the images here. You can see the mini PCL tract is going into the thoracic cavity and the nephroscope is inside. This was the post-op picture in which the nephrostomy was placed. And this is a small video in which we are going inside the thoracic kidney and we could see the stone here. And we did laser fragmentation as we generally do. Our most of the cases of PCNL, we generally prefer to do a mini PCNL, which helps us in a good way. And this case also we did with that mini PCNL approach. And slowly we fragmented all the stone, and we make sure that nothing else is spilling out of the system into the mediastinum because it could be actually devastating complication. So we could remove all the stone, and then finally we could place we could see the ureteric catheter, we could pass a guide wire here, and we could place a stent in this system. So guide wire is passed, and we placed a stent again. So The take-home message for this case is that intrathoracic kidney is a rare anomaly. This condition occurs due to accelerated kidney ascent or delayed closure of the clear-peritoneal membrane during fetal development. It may be associated with the diaphragmatic hernia, and kidney is inside the mediastinum outside the pleura. So PCNL can be done safely as we did in this case. So that's all, sir, from my side.
Excellent. Excellent cases, and it's also a session today. How crisply you use the words you have experienced, and first time I'm listening so closely. There are many words which are used very scientific and crisply, and I must appreciate. Not to praise you, but collection of the cases representing, keeping a take-home message for all the juniors. I want to give, this is the way a presentation should be done in any international forum or national forum, where there is a uniform format and there is a uniform representation of the cases, and always take-home message is very important. He has been given 1 hour. He finished in 48 minutes. He never exaggerated anything. All the cases are difficult. Some cases are very, very rare. So I think my purpose of conducting this session is absolutely served. This is what technical points we wanted to discuss. Science is always there, but experience in surgery, we all seen senior surgeon is senior surgeon. So they can tell the important tips and tricks which so many covered. I think in the last case, it is I don't have experience. I might have done RIRS, and if it is less than around 5,000 square cubic mm, or if the stone is less than 2 centimeter, but PCNL is always handy. Most of these kidneys are abnormally located posterior window through the paraspinal region, superficially entering into the kidney is the crux, because the vessels are unlikely there. The problem is any small deviation or the aorta, the cava will be side by, but unlikely if you are experienced in PCNL, it will go directly bullseye. Don't mind a little parenchyma and then enter into the pelvis. I think that is the correct answer. But pelvic ectopic kidney, this is may not be possible unless ultrasound guided, or as he has shown, laparoscopy guided. So he has shown Staghorn, he has shown pelvic ectopic kidney, he has shown thoracic ectopic kidney, infundibular stenosis, and then foreign body retained, and then normal routine case of the complex stone. So I am very happy. Thank you very much, Dilip sir. I think we will conclude the session.
Thank you. Thank you so much, sir. Thank you so much, sir.
Thank you.
Pleasure
Thank
of
you very
mine
much.
to be talking to you. Thank you, sir.
Thank you. Thank you.